So it's a real pleasure for me to have been invited to this meeting, not least because the last time I came to Philippines was roughly about 14 years ago. And coincidentally, at that stage, I was also speaker for the body that I was recently president for, and that is the World Society for Pediatric Infectious Diseases. Another reason why it's a real pleasure to actually be here today is it gives me opportunity of meeting a few people from the Philippines that I have actually grown to know over the past many years. And I'm fully conversant in terms of the great contribution which they've made to pediatric infectious diseases, not only in the Philippines, but also in a global arena. Now, what I'm going to do over the course of the next 45 minutes or so is really to take you through a journey. And for the most part, it's really a happy journey. In terms of the types of progress that's been made with regard to reducing under 5 childhood mortality globally. Before doing so, just to disclose a few of the interests which I have with different industry players, largely related to the work which I actually undertake in my own home country, South Africa. Now, the year 2013-2014, globally, the health of children has not been any better than at any other time in the history of mankind. And I'll come back to share with you some of the stats. And a large reason for that progress that's been made in reducing under 5 childhood mortality stems from the type of success which has been had with regard to vaccination. And I'll show you the dramatic effect which vaccination has had on a number of diseases since there's been a political will, including the funding being made available to actually impact on under 5 childhood mortality. And then I'm going to take you briefly through a journey in terms of what potential exists for the newer vaccines to further reduce under 5 childhood mortality. And lastly, but not least, it's really to take you in what I consider to be the next horizon when it comes to vaccinations geared towards actually impacting on childhood mortality. And what I'm really specifically referring to is vaccination of pregnant women and its importance in terms of improving child health. So these are estimates from 2010, and there is more recent estimates, but what I'd like to show is that between the year 2000 and 2010, the number of children that would have died globally has actually decreased. It's decreased from roughly about 9.6 million to 7.6 million. The figure in the year 2012 is even lower, 6.7 million. So clearly there's been tremendous declines in terms of under 5 childhood mortality, but I ask you to look at this figure a bit more closely. Now, the first aspect which I need to point out to you is that in the year 2010, 40% of children would have died before they reached the age of 1 month. So 40% of all children that die under the age of 5 are actually dying in the first months of life. And I think that is something which I want to flag and something which I'll come back to in terms of vaccination can actually impact on that death in the first month of life. We just heard from the past speaker that pertussis, as an example, is a disease which can actually kill children or affect children under 1 month of age. And in fact, globally, the group of children that are most affected by pertussis and who account for about 60 to 80% of all children that die from pertussis are children under 2 months of age. And clearly, those children are way too young to actually benefit from pertussis vaccination. Now, is there a different strategy that we can think about in terms of trying to confer immunity to that very young group of children and somehow aid towards reducing neonatal mortality? But the other part which I need to show to you, which I need to point out to you in this figure, is that even though there's been declines in terms of mortality from pneumonia and diarrheal disease, outside of the neonatal period, those two diseases remain the leading causes of under 5 childhood mortality. Now, the fact that diarrhea and pneumonia remain a leading cause of under 5 childhood mortality in this day and age is sort of an indictment in terms of the healthcare system. And the reason why I say that is that children shouldn't be dying from pneumonia and children shouldn't be dying from diarrhea, irrespective of whether or not there's vaccines. But the reason why children die from these diseases is a simple issue of access. It's an issue of access to life-saving interventions, which really cost a few cents. And the type of life-saving interventions that I'm referring to are interventions that have been discovered way back in the 1940s, such as penicillin, or something as simple as oral rehydration solution for diarrhea. Yet we find millions of children dying from pneumonia and diarrheal disease. And I'll come back to that in terms of what are the challenges and why do children still continue dying from these preventable diseases. Now, I think everyone in this audience is fairly familiar with the MDG4 goal. And what the MDG4 goal set out to do was to try to reduce under 5 childhood mortality by 2/3 in the year 2015 compared to the 1990 levels. Now, that was something which was adopted in the year 2000, and for that mission to be accomplished, what was required is that generally there was meant to be an 8% year-on-year decline in childhood mortality for us to actually achieve that goal of reducing under 5 childhood mortality by 2015 compared to 1990. So how well have we performed in terms of reducing under 5 childhood mortality when we look at specific syndromes? And what this slide basically shows you as an example is that the year-on-year decline in pneumonia is only 3%, for diarrheal disease 4%, for malaria 4%. But the two diseases which stand out in terms of exceeding the 8% target of a year-on-year decline are measles and neonatal tetanus. Now, what is different of measles and neonatal tetanus from, example, pneumonia and diarrhea? And obviously, what most people would appreciate is how those diseases differ from the others is that we've had vaccines. We've had vaccines for those diseases which have been with us since the 1930s, which have been with us since the 1970s. And I'll show you it's really the upscale of the use of the vaccines which have actually assisted us in terms of reducing measles mortality, in reducing neonatal mortality at such an accelerated speed. Whereas for those other diseases, we do have some vaccines, but those vaccines haven't really been rolled out yet to really assist us in terms of reaching the target of the MDG4 goal. So let us briefly explore some of the successes, some of the tremendous successes when it comes to vaccination. So now I'm taking you back almost 1 decade ago, but I'm taking you back 1 decade ago for a very important reason. And that is in the year 2002. Each year, there were about 10.5 million children that died, and of those 10 million children that died, roughly 25% of those children would have died from diseases which were vaccine preventable. But what's more disconcerting is that if you look at the causes of those deaths, over 50% of those deaths were actually occurring from diseases for which vaccines have been available as way back as the 1930s and 1940s. So vaccination against pertussis, vaccination against tetanus, these are not new vaccines. These vaccines were actually developed in the 1930s and 1940s. Yet in the year 2002, roughly 500,000 children were still dying because of tetanus and pertussis. Haemophilus vaccine, a vaccine that was first introduced in the 1980s. In the year 2002, 386,000 children were dying of haemophilus. Measles, we've heard of the measles outbreak that's occurring in the Philippines right now. Measles, a vaccine that was actually developed in the 1970s. In the year 2002, 540,000 children, 500,000 children were still dying of measles simply because of lack of access to the vaccination largely. Thanks. Now, the other two syndromes, the other two diseases that have gotten this are deaths from pneumococcus and deaths from rotavirus. And I'm going to come back to this in a bit more detail, except to say that over 1 million children in the year 2002 were dying from pneumococcal disease and from rotavirus disease. Now, measles is a good example in terms of how much can be achieved by vaccination as well as how quickly you can actually impact on childhood morbidity as well as childhood mortality, provided there's a political will and provided that vaccine reaches those children that require it the most. What this slide basically shows you is an increase in uptake of measles since the mid-1990s to the year 2006, and that has pretty much stabilized at that level. So in Africa, as an example, right now, about 80% of all children would actually be vaccinated with measles. In Philippines and similar in many other Western Pacific countries, roughly about 85% coverage with measles. But this increase of measles vaccination from roughly about 70% in the 1990s to roughly about 85-90% in the year 2010 has actually had a tremendous impact. So in the year 2000, as I mentioned, about 540,000 children would have died of measles. Of those 540,000, 64% actually would have died in Africa. Now, just to put this in context, children in Africa only make up less than 20% of the global under 5 population, yet they account for 2/3 of all measles deaths. Other regions of the world that are heavily burdened by measles include India as a country on its own, 16% of all cases, and then we've got the other regions. Now, what has been achieved with measles? Within the space of a decade, the number of children that die from measles has decreased from 535,000 to 140,000. Okay, there's very few interventions that can bring about such a speedy decline in under 5 childhood mortality. And if you look at Africa in particular, the measles mortality in Africa is only 50,000 per annum now compared to 340,000 previously, an 85% decline. And in fact, measles is one of the targets which actually has been achieved, where the aim was to reduce measles mortality by 90% between 2000 and 2010. And despite the type of outbreaks that we see nowadays, fortunately on a global level, that target has actually been achieved. So tremendous inroads has been made in terms of measles mortality. But that doesn't mean that we can actually become complacent, as we've learned from Philippines and certainly from many other countries, including in Europe, that measles epidemics are still here with us to stay unless we can reach a target of about 95, 98% coverage, which is really the level that is required to interrupt transmission in the community. Measles is going to be an illness which is going to be with us for some time to come yet. Now, what has been the benefit? What has been the number of lives saved because of this improvement in terms of measles vaccination compared to there being absolutely no vaccination in the world? And roughly in the past decade alone, 10 million children, 9.6 million lives have been saved with this increase in measles coverage. So this has been a great success story. But challenges remain. And the major challenge which remains is that even though measles cost a few rands, a few pesos, a few dollars, even less than $1, there's still an issue of access. And there's an issue of access where children in the poorest quintile of the world are less likely to receive measles vaccine compared to children in the richest quintile. And the problem with that is that it's these very children in the lowest quintile of the world, in terms of their economic status, that have got the least access to health care. So globally, less than 50% of children that come from the poorest quintile in the world will receive measles vaccination compared to about 85% for children that come from the wealthiest quintile in the world. So this is a major challenge which we actually face. And this challenge exists through most of the regions of the world. Now, the next disease that I want to talk briefly on is Haemophilus influenza type B. So the first vaccine that was licensed for HIP, which was the HIP conjugate vaccine, which was licensed in developed countries, was licensed towards the end of the 1980s. In the year 2000, almost 1 decade after the vaccine became available in developed countries, the number of children that would have died from HIP disease globally was about 370,000. That's over and above the other 18 million children that would actually have developed invasive HIP disease. Most of those deaths, again, taking place in developing countries. Again, 50% of those deaths actually taking place in Africa, in the Western Pacific region, Southeast Asia, roughly about 100,000 deaths from HIP disease alone. Now, 1 decade after the HIP conjugate vaccine became available, the only countries where HIP conjugate vaccine was being used was not in the countries that suffered the greatest burden of HIP disease, but rather the developed countries, where there was HIP disease, where HIP was the #1 cause of meningitis as an example, but certainly where the mortality and the morbidity in those countries was nowhere near comparable to what existed in low-income countries and middle-income countries. Fortunately, things have changed. In the year 2013, we can now boast that a majority of countries in the world have actually introduced HIP conjugate vaccine. But that has come at a cost. It's come at a major cost, not in terms of money, but in terms of the number of lives that have actually been lost because of the delay with the introduction of HIP vaccine. And what this slide basically shows you is the uptake of HIP vaccine in different parts of the world, in the developed countries, in low-income countries, in middle-income countries. What you see, HIP vaccines became available in the mid-1980s, and within a decade, roughly about 85 to 90% of industrialized countries had actually introduced HIP conjugate vaccine into the immunization program. In developing countries, almost 30 years after hip conjugate vaccine became available, less than 25% of developing countries had introduced a hip conjugate vaccine into the immunization program. It's only in the more recent years, in the past 5 years, that figure has now gone up to 95%. So basically what we're saying is a vaccine that's required the greatest, where the need is the greatest in developing countries, those vaccines are only becoming available to children in developing countries almost 30 years after those vaccines are actually becoming available to children in developed countries. And that is a type of inequity which basically is difficult to deal with. It's an inequity which comes not because of who you are, but rather of where you are born, and what type of a government you've got, and what type of a healthcare facility you've got. And those are the type of things which unfortunately are completely out of the control of children. Now what we've got is that if the current coverage of hip conjugate vaccine goes to the current global coverage of DTP3, we can expect to save another 125 to 150,000 lives each year. So what I'd now like to move on to is basically share with you some of the experiences and some of the updates in terms of reducing childhood mortality with the newer vaccines. And in particular, I'm going to be talking about two vaccines, and that is the pneumococcal conjugate vaccine and the rotavirus vaccine. But before doing that, what I need to show you, and some of you are familiar with this graph, is that a number of new vaccines that have become available to improve the health of humans globally over the past 20 years has been unparalleled in the history of the world. This is a difficult slide to read, so I'm going to take you through it. If you look at the last 20 years on the slide, between 1990 and 2010, in that 20-year period, there have been 16 new vaccines that have actually become available. 16 new vaccines in a period of 20 years. If you look at a 20-year period before then, between 1970 and 1990, there were 8 new vaccines that became available. And if you look at the 20-year period before then, there were only 4 new vaccines which became available in that 20-year period. So there's been an explosion in terms of the number of new vaccines that are becoming available. And for many of these vaccines are actually vaccines which are targeted at children and which are targeted at addressing the most important causes of death in children under the age of 5. And included in that are 2 vaccines which actually target the dominant causes of the dominant syndromes causing death in children under the age of 5, and that are vaccines against the pneumococcus, which is a major cause of death from pneumonia, and rotavirus vaccine, which is a major cause of death from diarrheal disease. So those are the 2 new vaccines that have really become available since the year 2000. Now, as I mentioned earlier on in the talk, the fact that children still die of pneumonia and children still die of diarrhea is really not because we don't have vaccines to prevent it, but it's rather because these children don't actually have basic access to health care. There are a number of different interventions, both preventative interventions such as exclusive breastfeeding, and therapeutic interventions such as simple things as oral rehydration solution for diarrheal disease, or just providing simple penicillin, which will prevent over 40% of all deaths from pneumonia, irrespective of the cause, 40%. Provision of penicillin. So there's a number of interventions that are available to us to actually prevent children from dying from these diseases. But the reason why children still die from these diseases is largely an issue of access to basic health care. We're not talking of heart transplant here, we're not talking of liver or lung transplants, we're talking of basic health care. And what this basically shows you on the slide is that less than 1/3 of children that develop diarrheal disease will actually be treated with correct oral rehydration solution. Less than 1/3. When we look at pneumonia, in terms of the number of children with suspected pneumonia that receive antibiotics, that ranges anything from 18 to 62%. In developing countries, 29% of children with pneumonia would actually get a proper antibiotic. Now, this is the reason why children are still dying from pneumonia and diarrheal disease, not because they don't have rotavirus vaccine or pneumococcal vaccine. They're dying simply because they don't have access to basic health care. So how can vaccines actually bridge this sort of a gap? The problem with curative services, as we all know, is that the further you go into rural areas, the further you go into marginalized communities, the less likely those people are going to have access to healthcare. So it's an issue of having access to curative healthcare and a healthcare system which functions. Now, unlike the logistics that are involved in terms of having access to curative healthcare, the logistics of actually providing vaccines is something which is much easier. It's much easier because it's much less vulnerable to type of different changes that might take place. It's something which is given on a very systematic basis. But it's only achieved if those vaccines are actually provided at an affordable price and where there is the commitment part on governments as well as in terms of donors and companies to make those vaccines available to those who require it the most. I mentioned that less than 1/3 of children with pneumonia will actually get antibiotics. And again, similar as was the case for measles, children that comes from the poorest quintile, and that speaks to the issue of lack of access to curative health care, children that come from the poorest quintile are less likely to get that antibiotics than children that come from the richest quintile. So what is the potential of the pneumococcal conjugate vaccine in terms of impacting on under 5 childhood mortality? Again, these are slightly outdated figures. These are estimates for the year 2008. In the year 2008, the pneumococcus was the single most important cause of death in children under the age of 5. More important than malaria, more important than HIV, TB, or any other disease that you want to think about as a single cause of death. 830,000 children would have died of pneumococcal disease, and the majority of those deaths was not because of meningitis, but because of pneumonia. 90% of all pneumococcal disease would have occurred from pneumonia. And what you see at the bottom of the slide is a number of deaths that actually take place in different regions. In Southeast Asia, about 200,000. In Western Pacific, about 43,000. And over 50% of these deaths, unfortunately, taking place in Africa itself. Now, we're fortunate. We're fortunate in that in 100 years, over 100 years since the discovery of the pneumococcus. The discovery of the pneumococcus took place in 1886. And since then, people have been working towards developing pneumococcal vaccines. And it was only in the year 2000 that a vaccine was actually developed, which was found to be efficacious in children who suffer the greatest burden of pneumococcal disease. These vaccines have now been rolled out in a number of developed countries, a few middle-income countries, and increasingly in a number of developing countries. The results that we've got that we have right now in terms of the effectiveness of this vaccine is mainly from developed countries. And what it shows us is that what we've got available to us, and this is just experience with a 7-valent pneumococcal conjugate vaccine, what it shows us is what we've got available is a vaccine that's highly effective. In all of the studies, once the vaccine actually introduced into public immunization programs, there's been an 80 to 100% decline in vaccine serotype-specific invasive pneumococcal disease. So we've got potent vaccines. As I mentioned, the majority of deaths that occur from pneumococcus is because of pneumonia. So it's important to actually measure how well these vaccines perform against pneumonia. Now, when we think of pneumonia, we're not just thinking pneumococcus. We're thinking RSV, we're thinking influenza. There's a whole lot of different pathogens that cause us pneumonia. So we don't expect a pneumococcal vaccine to prevent all of the pneumonia simply because pneumonia probably makes up about 1/3 of all of the, pneumococcus makes up about 1/3 of all of the pneumonia cases that we see. But what has been observed in developing countries, again, with the pneumococcal vaccine in reducing all-cause pneumonia is anything between a 25 and a 55% reduction. If you average that out, about a 30%, 35% reduction in all-cause pneumonia hospitalizations since the introduction of the pneumococcal vaccine. But perhaps the most telling figure in terms of what the worthiness of this vaccine is, in terms of improving the health of children under the age of 5, is a study that was done in a very low-income country, that is the Gambia. And what they showed in the Gambia is vaccination of children at 16 and 14 weeks was able to reduce all-cause under 5 mortality by 15%, by 16%. Roughly translated, for every 1,000 children that were vaccinated, the lives of 7 children were saved. And there's very few interventions that can give you that sort of a return. Vaccinate 1,000 children, vaccinate everyone in this hall here right now, and we'll save 7 of you from dying in the next 2 years. I don't think there's very few of you that will say, I don't want that vaccine. So this is the type of vaccine that we're referring to. Now, one of the impediments towards the uptake of vaccine in developing countries has been a concern about differences in terms of serotype coverage with a pneumococcal vaccine. As we know, the pneumococcus has got 93 different serotypes, but fortunately, it's a minority of those serotypes that causes the majority of disease. Certainly, with a 7-valent vaccine, it came short. It came short in terms of its coverage. So, as an example, in Asia, 38% coverage for the disease-causing serotypes in children, 62% in Africa, whereas in Europe, in North America, it ranged between 70 and 86%. But that challenge has been partly redressed with other vaccines that have become available on the market, which have included new serotypes, and now we've got a 10 and a 13-valent vaccine, which are fairly similar in terms of the coverage that they have in different regions of the world, anything between 70% to up to 90%. So we've got now vaccines which are more applicable to most regions of the world. Yes, was the case with hip vaccine, but fortunately there's been improvement. The pneumococcal conjugate vaccine became available in the year 2000. By the year 2010, about 75% of developed countries, industrialized countries, had introduced a vaccine. At the same time, we find that 30% of low-income countries and roughly about 30% of middle-income countries had also introduced a vaccine. Remember, 20 years after the vaccine, less than 25% of low-income countries had introduced a vaccine. Yet for the pneumococcal vaccine, after 10 years after it becoming available in developed countries, we find 35% of developing countries have already introduced the vaccine into the immunization program. If the uptake of the pneumococcal vaccine in developing countries is the same as what the current coverage is for DTP3, we can expect 430,000 lives to be saved with the introduction of pneumococcal conjugate vaccine into immunization programs. And this just gives you sort of a graph. It gives you an idea as to in 2013, where that figure in low-income countries has now gone above the 50% mark. So more than 50% of low-income countries have now introduced a pneumococcal conjugate vaccine into the immunization program, about 15 years after it became available to developed countries. So there's been an acceleration in terms of the uptake of this vaccine into developing countries, largely because of advocacy. Rotavirus. Now, there's been a decrease in rotavirus death. There's been a decrease since 2004 and 2010, 1.8 million down to 0.8 million. At the same time, deaths from rotavirus disease has pretty much remained. There's been some decrease, 527,000 in 2004, 450,000 in 2008. But obviously, the magnitude of the decrease in overall diarrheal disease has been less than the magnitude of decrease in rotavirus disease. What's the reason for that? The reason for that has got nothing to do with vaccines. In fact, it's got something to do with which is more basic than vaccines, and that is access to clean portable water. So the value of having access to clean portable water in reducing diarrheal morbidity and mortality can't be understated. In fact, vaccines only come second to clean portable water as a cost-effective strategy. And what this basically shows you is that with the improvement in access to clean portable water, that has actually resulted in tremendous decline in diarrheal-associated mortality. Just access to clean water itself is expected to reduce diarrheal mortality by up to about 40 to 50%. And that's the reason for the decline in all-cause diarrheal mortality that we've seen in children. Now, in the year 2008 again, there were about 450,000 deaths that occurred because of rotavirus. Of those deaths distributed throughout the regions, about 290,000 in Asia region, about 230,000 in Africa. There have been a number of studies that have performed rotavirus vaccine, and what this basically tells us is that we've got a vaccine which is effective, but which is not consistently effective across all parts of the world. What this graph basically shows you is at the bottom here, you've got a GDP. You've got GDP here, and that is vaccine efficacy. If you come from countries, industrialized countries, the vaccine efficacy is much higher than in countries with lower GDP, right, with low-income countries. So in low-income countries, the vaccine efficacy ranges from 50%, in Vietnam about 73%, South Africa 76%, in developed countries close on to 100%. Now, we're not too sure exactly what the reason for this is, but as we know, for most life-attenuated vaccines, those vaccines generally are less efficacious in developing countries. So it's not something specific to rotavirus. Does that mean rotavirus vaccine is not important for developing countries? And the answer to that is no. When we look at vaccine efficacy, we also need to think about it in the context of the number of children that will be protected. So a vaccine efficacy of 100% for a very rare syndrome is much of less public value than a vaccine efficacy of 50% for a disease where many people are actually killed in terms of the number of lives that will be protected. The effectiveness of the vaccine has been shown in a number of different studies. It's reduced all-cause hospitalization by about 70%, it's reduced all-cause hospitalization by about 40%, rotavirus-specific hospitalization by about 70%. But perhaps most important is the impact of this vaccine on mortality. Roughly about a 1/3 reduction in all-cause diarrhea mortality with the introduction of the rotavirus vaccine. And this was the first study to actually show us, a study in Mexico, where in the first year after the introduction of rotavirus vaccine, there was a 40% decrease in all-cause diarrhea mortality in children under the age of 1, and a 29% decrease in children between 1 to 2 years of age, despite children 1 to 2 years of age actually not being targeted for rotavirus vaccine. The uptake of the vaccine is still at an early stage. In the year 2013, we find that a number of low-income countries, in addition to some middle-income countries, have now introduced rotavirus vaccine into their immunization programs. Okay, so in the last few minutes, I really want to talk about sort of an emerging field in terms of vaccination. We heard about the challenges of pertussis vaccine in the Philippines, but the challenges of infections in very young infants goes beyond pertussis. There's a number of other diseases. And the reason why this is becoming more important, as you can see from this slide for the Western Pacific region, is that of all children that die in the Western Pacific region, 54% of those children will die in the first month of life. So to make any further progress in terms of reducing under 5 childhood mortality, we really need to start impacting on mortality in the first year of life. And there are a number of different diseases, some of which can be prevented, some of which can't. I show you in this slide as an example, 15% of children that will die in the Philippines, not in the Philippines, in the Western Pacific region, will die simply because of complications of prematurity. Is that something that can be prevented by vaccination? I'm going to show you data which suggests that at least some of that prematurity can actually be prevented by vaccination. Other causes of death include pneumonia, include sepsis. Can that be prevented by vaccination? Certainly some or some fraction of it can be prevented by vaccination. Now, the only way in which vaccines are going to work in terms of protecting very young infants, newborns, is not by vaccinating the newborn. The newborn's immune system is immature. There isn't sufficient time to actually develop immunity. The only way in which vaccines can actually protect newborns would be to target the mothers, the pregnant women, vaccinate them during pregnancy. Is that the strategy that will work? Is there evidence to show that this will work? And the answer to that, the epitome of how successful such a strategy could be, comes from our experience with tetanus. So when we look at tetanus, and this is looking at coverage with tetanus, this is reports to the WHO, and it's probably just an underestimate, is that as the vaccination of pregnant women with tetanus vaccine has increased, there's been a tremendous decline in neonatal tetanus. So we know that by vaccinating mothers with tetanus vaccine, we can actually reduce neonatal tetanus. And I showed you in the early slide right up front, is that that's one of the diseases where the target of 8% year-on-year decline has actually been exceeded. Now, there's 4 vaccines, some of which are already developed and some of which are in a pipeline. Right, there's an influenza vaccine, there's a cellular pertussis vaccine, vaccines which are available to us. These are not new vaccines, but they haven't necessarily been used in pregnant women. And then there's a GBS, a Group B strep vaccine, which is basically going into phase 2 studies now, and an RSV vaccine targeted specifically at pregnant women, which is also going into phase 1 studies very soon. I'm just going to focus my talk, just show you 3 or 4 slides on influenza vaccination. And I think this is a vaccine which is especially important for regions such as Philippines, where you've got a much more perennial, you've got an epidemic of influenza, but from what I saw, influenza tends to circulate through most part of the year. Now, the landmark study, which actually suggested protection of young infants up to the age of 6 months by vaccinating their mothers, was a study which most of you are familiar with, and that was done in Bangladesh. In this particular study, where they were actually planning on looking at the effectiveness of pneumococcal polysaccharide vaccine in protecting infants, a finding of the study was that the children of the mothers that received a control vaccine, which was influenza vaccine, were less likely, 63% less likely, to develop influenza illness than the children of mothers who received a pneumococcal vaccine. So mothers were vaccinated with influenza vaccine, and the children were now 63% less likely to develop influenza illness. In the mothers, there was a 36% reduction in respiratory illness with fever, not all of which was influenza. This was all-cause respiratory illness. So I'm sharing with you now some unpublished data which will actually be presented in Cape Town this year. And this is in a different setting to see if what we saw in Bangladesh is actually true or not. And this is a study from South Africa, where we immunized about 2,100 HIV uninfected women, and we looked at influenza-confirmed disease in the mothers as well as in the children. And what we found is that vaccine efficacy in HIV uninfected women for influenza vaccine was 54% in the per-protocol analysis. 54% reduction in influenza-confirmed disease in pregnant women that receive influenza vaccine. In the infants, it's a similar protection. 49% reduction in influenza illness, confirmed influenza illness, in infants up to 6 months of age if their mothers were actually vaccinated with the influenza vaccine. Now, I mentioned to you influenza vaccine might also protect against prematurity. So we're looking at extension of protection not only to the infant, but also while the infant is in utero. Now, the association between influenza and prematurity dates back to the 1918 influenza epidemic, where they found that very soon after the Spanish flu epidemic, the number of stillbirths that took place was actually much greater than at other times of the year. In this recent analysis from the United States, they showed that children that are born during the influenza season are 17% more likely to be born prematurely compared to children that are born when there's no influenza circulating. In addition to which, what they also show is that children born to mothers that actually receive influenza vaccine are actually born at a higher birth weight. So children born to mothers that did not receive influenza vaccine are actually born at a lower birth weight. And it is because of that what we find is that the paradigm in terms of targeting women for vaccination has changed. In the United States now, they recommend vaccination with pertussis vaccine, with diphtheria DTaP, as well as with influenza vaccine for all pregnant women, irrespective of their gestational age. So in conclusion, what I've really tried to demonstrate is that there have been significant advances. There's been significant advances that have been made in terms of reducing under-5 childhood mortality since 1990, and a large portion of the success is attributed to improved vaccination against measles, etc. Further gains are to be made in terms of reducing under-5 childhood mortality with the introduction of rotavirus and pneumococcal conjugate vaccines into our immunization programs, as well as the possibility of impacting on early infant mortality by targeting mothers for vaccination both with influenza vaccine as well as with pertussis vaccine. But at the end of the day, this success will only be managed and will only be had if we've got sustainable, secured supply of life-saving vaccines at very affordable prices to low and middle-income countries, and particularly where we target communities that are the most economically marginalized in those countries. Thank you for your attention.